Hello and welcome to the COMLEX Instant Podcast. Today we're going to be talking about certain syndromes that you may encounter on the COMLEX board exam. Let's start with achondroplasia. What is it? Well, it's mainly an autosomal dominant disease where a patient has dwarfism due to early epiphyseal closure causing shortening and thickening of the bones. So the key words here: shortening, thickening of the bones, dwarfism, and autosomal dominant. The boards likes to test whether this disease has a genetic pattern that's autosomal recessive or autosomal dominant. So please remember that. Now the symptoms are patients presenting with leg bowing, hearing loss, sciatica, infantile hydrocephalus, and patients can have normal lifespan. So if you haven't seen a picture of a patient with achondroplasia, it's really important to go and look at a patient with achondroplasia. The characteristic signs again: autosomal dominant, leg bowing, hearing loss, shortening and thickening of bones along with dwarfism. Those are the key things you want to remember for the board exam. Next, let's talk about Alport syndrome. This is an X-linked hereditary collagen defect causing sensorial hearing loss, lens dislocation, and hematuria. And oftentimes patients present with glomerulonephritis as well. So the key board exam relevant points are hearing loss, lens dislocation, and hematuria. Next, I want to talk about alkaptonuria. The key word here is going to be a patient who presents with black urine and blue-black pigmentation of the ear, nose, and cheeks. Don't confuse this with lead poisoning just by looking at the colors that you see on the board exam. These patients have arthropathy due to cartilage binding the homogenistic acid. And again, there's a defect in the phenylalanine metabolism, which causes an accumulation of the homogenistic acid. So the key points for alkaptonuria include black urine, blue-black pigmentation of ear, nose, throat, arthropathies of the cartilage, and a defect in phenylalanine metabolism. Next, I want to talk about Banti syndrome. Now, this is a condition where a patient presents with idiopathic portal hypertension. The word here that you want to remember is portal hypertension. And along with that, patients will have splenomegaly. This is usually following a subclinical portal vein occlusion. So, Banti syndrome, you're thinking about the liver with hypertension. So, portal hypertension, splenomegaly, portal vein occlusion. And again, it's an insidious onset occurring years after the initial occlusive event. Next, I want to talk about Argyria, Argyria. This is a dermatological condition. Patients have a deposit of silver bound to the albumin, and it's related to prolonged exposure or ingestion of silver-containing products. So it's a classic scenario on the boards where patients come in and they have slate gray skin color, including the mucosa and the sclera. The treatment is going to be psychosocial support, and again, discoloration is irreversible. So on the board exam, if you see a patient with a silver containing grayish like skin color, and it's again related to some exposure or ingestion of a silver containing product, then you're going to select Argyria as your answer choice. I want to next talk about Albert-Schronberg's disease and osteopetrosis. Okay, the key word here is that there's an increase in skeletal density. Skeletal density is increased here, and it's due to the increase of osteoclastic features. Wrong. Actually, it's due to a failure of the osteoclastic features. So, on the board exam, Albert-Schronberg disease, increased skeletal density, osteoclastic failure, multiple fractures are present in patients usually, and that's due to the decreased perfusion of the thick bone. Also, it causes anemia, and there is a decrease in marrow space. Patients can have deafness, cranial nerve dysfunctions, and there can sometimes be an impingement of the neural foramina. So let's review Albrecht-Schoenberg disease and osteopetrosis. Again, keywords: skeletal density increase due to osteoclastic failure, leading to multiple bone fractures, causing anemia, and causing deafness and cranial nerve dysfunctions. Next, I want to talk about ataxia telangiectasia. This is a DNA repair defect disorder. So on the board exam choice, you may have a classic presentation of a patient with ataxia telangiectasia, but the answer choice may show DNA repair defect. So it's important to know its pathophysiology a little bit. There's defects in BNT lymphocytes causing the DNA repair defect. It is autosomal recessive, and it appears by age 2, and the physical signs usually include ataxia of the gait, telangiectasias of the skin and conjunctiva, and recurrent skin infections. So remember those three: ataxia of the gait, skin telangiectasias, and recurrent sinus infections. Next, I want to talk about another condition that you may see: adrenoleukodystrophy. This is an X-linked defect in the long-chain fatty acid, and it's due to a paroxysmal enzyme deficiency. So it causes rapidly progressing central demyelination, and that's the key word here. Also, adrenal insufficiency and hyperpigmentation of the skin, leading to spasticity, seizures, and often death by early age, such as 10 or 12 years old. So remember that: adrenoleukodystrophy, central demyelination, adrenal insufficiency, and hyperpigmentation of the skin, causing also spasticity and seizures and early death. If they ask you the genetics, it's X-linked recessive, and there's often a paroxysmal enzyme deficiency that's present. So that was an overview of some of the common conditions you may see as syndromes on the board review. Please visit COMLEXFlashcards.com for additional podcasts and board review material. That's COMLEXFlashcards.com, and good luck in your preparation.